Hello, everyone. My name is Dr. Christy Mulholland. I'm an assistant professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. I am the director for the Faculty Wellbeing Champions program for the Icahn School of Medicine across the health system. And I'm recording this talk for you on August 30th, 2024. And you are listening at some point in the future. It is nice to connect with you. My talk today is about clinician well-being in geriatrics and palliative medicine. Here are the topics we'll cover. Of course, we can't talk about clinician well-being without talking a little bit about burnout. We'll talk about specific considerations in geriatrics and palliative care. We'll go over a well-being proposed definition as well as a model. We'll discuss recommendations and a review of the evidence in geriatrics and palliative care. We'll talk about establishing a well-being program. And I'll go through an example of a well-being initiative at my program. Lastly, I'll leave you with a few resources for yourself and your teams for well-being resources for geriatrics and palliative care teams. So let's dive right into the burnout problem. By now, you've heard about the burnout problem, and I'm going to try to talk about some salient points in the history of how we've talked about burnout and how it informs our efforts to improve well-being. So we are a workforce in crisis, and we have been for some years. Of course, the COVID pandemic put a spotlight on this issue, but did not begin in the pandemic. It predates the pandemic. It continued and was exacerbated by the pandemic, and now it goes on. So many attribute the burnout crisis to a few factors. First, let's think about what's happening in healthcare reimbursement. We are in the midst of a shift from fee-for-service based care to value-based reimbursement, and we're kind of somewhere in between. Our clinicians are being asked to do more with less resources, and at the same time to see more patients and be more productive, all while the patients are getting more complex and the treatment landscape is more complex. Additionally, the rise of the electronic health record. This is something that has offered easy access to patient information. It may improve patient care, and it definitely has had the unforeseen downstream consequence of creating and largely contributing to burnout in our clinicians. Some efforts to improve burnout have had unforeseen downstream consequences. Our residents and our trainees had the improvement of placing duty hour restrictions. So they can't work 120 hours a week. But by meeting those duty hour restrictions, a new phenomenon of work compression has arisen. And work compression means you still have to get all of the same tasks done, and now you have fewer hours to do it. All of these factors impact our time at the bedside with our patients, which is where we derive meaning from our work. And we're spending more time at the computer entering data and looking over data. This challenges our ability to find meaning and purpose in the most rewarding aspects of our work. In 2019, the burnout problem was recognized as a national public health crisis. I'll talk about the paper that described it. And burnout rates, as they've been measured over the years at different points, I'll give you just an idea, but in US nurses, it has been measured at around 35%. Among physicians, the burnout rate is 48.2 to 49%. These are data from 2023. And even among med students, they haven't even started their careers yet, but 45 to 60% of med students and residents meet the criteria for burnout. So what does burnout look like? The most widely used burnout instrument in healthcare is the Maslach Burnout Inventory, or MBI. This has 3 dimensions. The first is emotional exhaustion. So in burnout, a high emotional exhaustion score is consistent with burnout. Depersonalization is high. Depersonalization means cynicism or an inability to see your patients as human beings. And sense of personal accomplishment is low in burnout. There are other instruments that measure burnout as well as other related mental health distress: the Mayo Clinic Wellbeing Index, the Resilience Scale, the Meaning in Work Scale, depression screening, and numerous other ways of trying to capture a very complex condition. There are many consequences to burnout. There are threats to the individual, such as occupational injury, alcohol use, suicide risk, regretting one's career choice or thinking about leaving your career early, suboptimal professional development. And then, of course, the threats to society and to the healthcare system. Burnout threatens professional behavior, the quality of care, patient satisfaction scores, patient safety. There are financial consequences of burnout. Turnover is expensive. Absenteeism, or not showing up to work. Presenteeism, showing up not ready to work, being physically ill and still showing up to work, for example. And productivity can suffer when clinicians are not functioning at their highest level. So there are some considerations I'd like you to think about in geriatrics and palliative care. Why should our organizations care, particularly in geriatrics and palliative care? So we are, as you know, a workforce in demand. The demand for geriatrics and palliative care far exceeds the current supply of trained palliative care and geriatric specialists, as well as there aren't enough generalists that are good at these primary foundational palliative care and geriatric skills. In addition to that, the US population is aging and the need for geriatricians is rising. In palliative care, there are a lot of advances in treatments for serious illness, which means that the population of people living with serious illness survives longer and they need more help making complex decisions. So in order to expand the vital access to geriatrics palliative care, we need to not only sustain our workforce and keep the people that train to go into our fields, but we need to attract more people to our specialties and grow. Well-being is sustainability. Well-being is sustainability. We need well-being practices for our organizations and our individual clinicians to sustain our workforce so that we can get the care to the patients. Our organization leaders, they worry about the cost of burnout, and they're right to worry, and we need to develop the vocabulary to make a really good financial case. There is a very simple financial case, which is that burnout is associated with increased costs related to turnover. And one author estimated that the cost of burnout for organizations is approximately $7,600 per employed physician per year. What are some well-being factors that contribute to well-being in geriatrics and palliative care? So in 2016, Arif Kamal published this survey of palliative care and hospice clinicians and measured the burnout rate at 38.7%. This has remained pretty consistent even throughout the pandemic years. Higher odds of burnout were associated with non-physician clinical roles, so our nurse practitioners, our social workers, etc. Also working in smaller organizations, working longer hours, and being younger than 50 years of age, and working weekends. Activities that were rated highly that mitigate burnout are participating in interpersonal relationships and taking vacations. Among geriatrics care facility workers, burnout rates have been measured between 25 to 75%. Some of the characteristics of the older adult and seriously ill populations that we work with, so these are vulnerable populations. We as clinicians are with people through a lot of grief. We're providing bereavement support. There's the potential for our own emotional exhaustion, vicarious or secondary trauma, and moral injury. On the flip side, we do have some built-in practice tools that might actually be really helpful at addressing burnout, including learning effective clinician-patient communication skills, providing care in interdisciplinary teams, and having routine structured debriefings. Although we do need more research to demonstrate the relationship of these built-in practice activities with well-being. So now I'll go over some proposed definitions and a conceptual model to think about. And we propose that well-being is equated with professional fulfillment. We're emphasizing professional fulfillment because what we're talking about is optimizing well-being in our workplaces. We're limited in our ability to reach out to people's home life or personal life and optimize well-being there. So we're focusing on what we can to optimize for professional fulfillment. So professional fulfillment, what is this? Professionally fulfilled physicians are defined as those who experience happiness or meaningfulness, self-worth, self-efficacy, and satisfaction at work. And professionally fulfilled physicians are better equipped to practice clinical care and research, but also to lead efforts to improve the healthcare system. How many of us are professionally fulfilled? Well, out of physicians, 39.3% out of 18,000 some physicians met the criteria for professional fulfillment in the US in 2023. We can definitely do better. This is the Mount Sinai Icahn School of Medicine model for professional fulfillment and meaning in work. And this is adapted from the Stanford model and the National Academy of Medicine model. You'll notice that the aim on the right-hand side of the screen is a group of professionally fulfilled clinicians finding meaning in their work. The gears on the left represent 4 domains of professional fulfillment. The blue gears, you'll notice, are somewhat larger, and the pink gears are a little smaller. The blue gears represent what we can do to improve the system. And workplace efficiency and function and workplace culture are things that organizational leaders can improve so that the systems function better for everyone to enhance professional fulfillment. The pink gears represent individual level factors, personal factors in health and mental health support for individual clinicians. And what the system can do there is minimizing the barriers, any barriers of working in this workplace that might prevent our individual clinicians from being able to access the things that make their health better or accessing mental health support. This model can be applied to you. This is my representation of how I think about these gears in my own life. So that's me on the right, having a moment during the early pandemic days when I was feeling very tired but quite professionally fulfilled and finding a lot of meaning in my work. Going through the gears, starting at the bottom, the workplace efficiency and function gear, you can see from my inbox that I do not delete my emails to zero. They're just all living in my inbox. And I find that the clerical burdens I experience from all of my electronic communication tools and apps and devices, they can be quite draining, quite emotionally draining to me. I also channel a lot of my work-related efforts on well-being into reducing clerical burdens and reducing things like inbox burden. Moving to the left, workplace culture. Mount Sinai Hospital has been rated several years running as the #1 hospital in the nation for geriatrics. That's not meant to be self-promoting, but actually just to illustrate the pride that we have in working in this department in this health system, and we are very mission-oriented. We really believe in the care of older adults and improving the quality of life for our patients with serious illness. And so that culture is very alive and well, and yet we are constantly threatened by the functions and dysfunctions of the healthcare system to allow our culture, which we are very proud of, to continue thriving. Moving to the personal factors in health, exercise and movement. I rely on those things to sleep well at night, to feel good in my body, to be able to withstand long hours moving around in the hospital. And this was something that I let sort of lapse during my residency years. And I did experience a lot of burnout during that time as well. And in my fellowship and attending life, I've been able to rekindle that. And New York City has a wonderful range of studio fitness options that I take advantage of. And then mental health supports. A role model, my program director for my fellowship, made a gentle recommendation that each of us consider accessing the free student health resources at Mount Sinai, and I took her up on that, and it was a wonderful opportunity to experience psychotherapy and also move into psychoanalysis. I was able to address kind of my immediate issues, which at the time was burnout recovery, but also delve more deeply into some of my childhood experiences and how they informed me as a doctor. I found myself just becoming a better version of a doctor and a better version of myself through psychoanalysis. So you can think about each of these gears for yourself, and even this is probably an oversimplified version of my life and my work-life balance, but it's a starting point. And if we are intentional in our own lives about keeping these things in balance, we can become better clinicians and better well-being champions. So I'm going to go through some overarching recommendations for a well-being program and initiatives, and I'm going to go through some specific evidence with an emphasis on evidence that comes from geriatrics and or palliative care. This is the white paper describing physician burnout as a public health crisis in 2019. This is a crisis in healthcare, a call to action on physician burnout, and it comes from the Massachusetts Medical Society, the Harvard School of Public Health, and the Harvard Global Health Institute. The main takeaways from this paper, it was recommended that all institutions have a chief wellness officer to lead system level change. So that emphasis on changing the system, that has been a main highlighted recommendation since the early days of naming this public health crisis. And also an emphasis on improving the electronic health record to reduce burnout. The authors made a recommendation that well-being should be addressed early in training, which makes a lot of sense considering that medical students are coming out of school already with significant burnout rates. We all need well-being practices throughout our career, and the earlier we learn them, the better. Taking action against burnout comes from the National Academy of Medicine, and this went into a little more granular detail about how to begin addressing the burnout problem in organizations. And this paper recommends system-level solutions aimed at reducing or preventing burnout for clinicians of all types across all stages, urging healthcare leaders to take action to uphold clinician well-being as a fundamental value that is essential to the fulfillment of their missions. Specifically, this paper at length goes through 6 steps to take action against burnout. The first is creating positive work environments. Kind of goes along with the workplace culture gear in our ICON School of Medicine model. Address burnout early in training and in the early career stage. Reduce tasks that do not improve patient care. The AMA calls this gross, or getting rid of stupid stuff. One great example from the AMA website about the GROSS program is how one institution realized that in EPIC, all clinicians were being prompted to rule out male patients and elderly patients from being pregnant before they could place an X-ray order. So they decided that the burden of that task was not helping patients, and they made it a priority to get rid of it. 4, improve usability and relevance of health information technology. 5, reduce stigma and improve burnout recovery services. And 6, create a national research agenda on clinician well-being. The experts recommend a multi-fold approach, and I do as well. So well-being programs should include both system-level interventions For example, improving the usability of electronic health records. System-level interventions are things that can change in the workplace environment that will reach everybody or almost everybody working within that environment. Individual level interventions, on the other hand, is work that can be done with individual clinicians to, build their resilience, for example, cultivate a sense of meaning in work. And a well-being program should include both of these types of interventions. I think that over the years there has been a little bit of pushback or a little bit of reaction from clinicians against individual level interventions. I hear the joke that our workplaces will try to make everything better by giving us mandatory yoga classes. That's not what we're trying to do. It's very clear that improving the system is the most important, and at the same time, providing opportunities for individuals to learn different practices such as mindfulness-based stress reduction, which we'll talk about a little bit later. Those opportunities, and I encourage that type of thing to be optional, but if we can offer that as well while also working hard to change the system, I think that is a very well-rounded well-being program. I'm going to go through each of the gears, each of these domains in a little more detail and go through a little bit of the evidence for each. So we'll start with workplace efficiency and function. The evidence for improving workplace efficiency. First, working in the electronic health record is associated with burnout, and there are multiple studies demonstrating this. This is very replicable. Time in the electronic health record is associated with burnout. Clinicians report frustration working in the electronic health record, and people are working extra hours outside of their scheduled work hours, which is interfering with work-home balance. Next, in-basket burden interrupts vacation time, which is associated with burnout. So interrupting vacation time, the majority of physicians in a very large survey admitted to or shared that they were doing work-related tasks while on vacation. Also, taking less vacation time or having vacation time interrupted was associated with burnout. This is a gender equity issue. There's a gender gap in electronic health record work. Women physicians have been found to spend 7 hours on the electronic health record for every 8 hours of scheduled time, while their male counterparts only spent 5.3 hours. This is especially noteworthy in geriatrics and palliative care, both of which fields are predominantly female. That last study is an example of a successful initiative to reduce in-basket burden on clinicians, on physicians specifically. And I included that because I think there is substantial literature describing, or in other words, admiring the problem of burnout. We don't necessarily need too many more studies telling us that the EHR is attributed to burnout. But it is, I think, really inspiring and hopeful to see an example of a program that worked. And this team over several years was able to reduce in-basket burden on their physicians by about 22 or 25%. So the evidence is that if we invest resources in programs like that, they can work. Looking at workplace culture, the evidence for improving workplace culture. So we know that strong leadership increases team engagement, improves overall quality of care, increases productivity, improves patient satisfaction, and reduces staff and physician turnover, which I've told you are expensive. Furthermore, the leadership qualities of physician supervisors appear to impact the well-being and satisfaction of individual physicians working in healthcare organizations. One study looking at a composite score of a 12-item leadership index showed a 9% increase in professional satisfaction and a 3.3% decrease in burnout from only a 1-point increase on that 12-item scale. So the higher the leadership score, the higher the professional satisfaction of the physicians working under that leader, as well as a reduction in their burnout. Psychological safety. So one standard deviation in a score measuring psychological safety in a team or in a department was associated with a 30% lower odds of a physician in that department stating that they were likely to leave their job in 2 years. Another example of a program that works. So at the Mayo Clinic, Colin West and his team developed a program of self-facilitated physician small groups. So basically they got groups of physicians together. They gave them each 20 bucks to get some food, eat their food together, and they gave them a suggested list of topics. There was no trained facilitator. The physicians gathered, they talked about the suggested topic, they ate their meal, and they were measured to have lower burnout scores, lower depressive symptoms, and higher job satisfaction compared to a control group that did not go through the self-facilitated groups. So this is scalable, right? A program like that could be highly adaptable, and it could be implemented in many different kinds of work settings. Looking at personal factors in health. Some of the evidence, just a couple of examples here. So in palliative care, this team looked at a 10-week group mindfulness program led by an experienced meditation teacher and found that the program resulted in significant improvements in emotional exhaustion and in personal accomplishment. So those are two of the 3 dimensions of the Maslach burnout inventory. And if your program maybe doesn't have the time or the interest in such an extensive program, perhaps the smartphone app could help and contribute something. So another study showed that a smartphone-based mindfulness app intervention improved compassion fatigue and burnout among palliative care clinicians. And finally, the last gear, which is mental health support. A little bit of the evidence here, and this is in palliative care teams. So therapy-based supervision, an art therapy program for palliative care clinicians resulted in significant increases in emotional awareness compared to a standard skills-based supervision group. Balent groups, many of us have experienced Balent groups in our programs, and these are, for those who don't know, that these were developed by psychoanalysts and intended for I believe they started with family medicine physicians and have been adopted elsewhere. We do them among our palliative care teams. And Balent groups are an opportunity for a clinician to share with a group about their personal experience caring for a patient in a particular case and get some feedback and support from that group to improve their clinical skills. And also, Balent group participants have reported significant improvements pertaining to well-being, such as their burnout score, as well as 2 of the components of burnout, emotional exhaustion and depersonalization, alexithymia, which is the ability to recognize and name one's own emotions, and improvements in people's perceptions of their social support. And why is it important to improve mental health support for geriatrics and palliative care physicians and clinicians? These clinicians are at risk for secondary traumatic stress syndrome, which can include difficulty sleeping, intrusive thoughts. This is not uncommon among healthcare workers who are frequently exposed to working with seriously ill patients. So hopefully this evidence review has convinced you not only that well-being is of utmost importance, but also that well-being initiatives can help. And if I've convinced you of that, you're probably interested to know more about how you can establish a well-being program or what a well-being program should even entail. I mentioned this before, but this multifold approach, it has to address the systems and the individuals, right? So this means that leaders have to be involved in this. And program leaders must recognize that well-being is a shared responsibility between their individual clinicians as well as the organization. So it follows that healthcare leaders, program leaders in geriatrics and palliative care, they must recognize the importance of this and become well-being champions themselves. If you're fortunate like I am, you have a chair or you have a division chief or you have somebody that does believe in this already, and you don't have to argue for it too much. But I'm going to try to give you a little help if maybe the person leading your organization isn't as bought into this yet. But Effective leaders, they model personal resilience behaviors themselves. They take vacation. They tell their teams when they're taking vacation, and they set a good example about doing that. They also advocate for their staff wellness needs. They advocate for resources where they can. They consider the impact of programmatic decisions on employee well-being. This means that they try to avoid unnecessarily increasing productivity requirements without providing additional support or compensation. Leaders invest and support in and support well-being initiatives. Support can take many different forms. Support can be financial support. That's not always possible. Supporting the message and the mission, creating a space in team meetings to talk about well-being, creating infrastructure for well-being initiatives, supporting the interest of interested junior clinicians that might want to try and develop something. That can all be support, and all of those types of support are valuable. Leaders need to identify and support the professional development of well-being champions. So right out of fellowship, I knew I was interested in this, and I was very fortunate to find mentors in my team and my department who supported my learning more about this and applying for grant funding to try to make my impact more powerful. But that type of support for the right person can really be the beginning of a small well-being program that can grow. What does a well-being champion do? So well-being champions must start with a needs assessment, because your initiatives have to be grounded in data about what your population is experiencing and what type of well-being program they would even be open to. So you always have to start with a needs assessment that can look like a survey. It can be focus groups. It can be, talking to a representative from each different team in your organization. But you have to start by learning what is currently happening and what people need. And then using that needs assessment data to develop and pilot interventions to improve all of the 4 domains I've been talking about: workplace efficiency, workplace culture, personal factors in health, and mental health. A well-being champion should be aware of well-being resources in the organization and out of the organization, and keeping those things up to date. If able to do so, the well-being champion can be a person that other team members can come to if they're looking for resources, or they're maybe even looking to get connected with mental health supports, for example. So what if you're working in an organization with limited resources, which all of us are, but to varying degrees? So what if you really don't have any money to get this started, or you don't have any protected time? Here are just some thoughts and directions that I'll offer you. First, even if you hear, the initial response is there's no money for that, there's no resources for that, always remember there is a business case to support well-being initiatives, and you might be able to show an ROI, or a return on investment of spending a little money to make the workplace more efficient, which might increase the potential to see more patients in a day, for example. You can also think about showing the business case of reduced cost and clinician turnover. If your organization has already identified that turnover is a problem, maybe you can make the case that way, that we need to focus on retaining our employees. We have to have a well-being program, or people aren't going to want to stay here. Next, nobody can do this work alone. A geriatrics palliative care organizational leader cannot be the only champion for well-being, and one junior clinician can't be the only champion for well-being. This needs to happen on a team basis. Leaders have to work with frontline people. Administrative support can also be incredibly helpful. Interdisciplinary teams, and we're already great at this in geriatrics and palliative care. We work in teams already, and well-being should be no different. Make it count twice. In a limited resource environment where a lot of work is already happening, how can we think of ways, not to reinvent the wheel, or not to have a well-being program working in a silo? How do we make work count twice? And an example of that, or an explanation of what I mean by that, is that well-being initiatives can align really nicely with other work that's already happening, including QI initiatives. In my program, the fellows do a QI project every year. So I thought, why don't we, make one of the themes of one of the QI projects a well-being project? And a lot of well-being work can and should be approached as QI. How are we changing the workplace to improve quality? And this quality can be, do our clinicians have well-being? Are we efficient? So that can be one specific example of how to make your work count twice. You can keep things small or attack the low-hanging fruit. Do what you can with what you have. For example, there's a meeting that you already have every week or every month. Why not make the last 5 minutes of that meeting into a well-being or a resilience building activity, like a group debrief of a tough case or a bereavement exercise or a guided meditation. I'll give you an example of a well-being initiative in our program. This is the Department of Geriatrics and Palliative Medicine Community Building Project. Some background on this and the business case, how we got this rolling. We had a task force in our department post-pandemic, air quotes, post-pandemic. And in 2023, we were looking at the impact on the shift to remote and hybrid work in our department. And a lot of the findings, a lot of the comments from that in particular mentioned this idea that we might have lost something in terms of community. People are spending less time kind of hanging out in the office suites and chatting with each other. And we're doing a lot more of our meetings on Zoom and we're working from home, which has great flexibility, but what about our community? So there was interest and there was data for this program. We also had the ability to get some funding through a philanthropic grant of a private palliative care foundation. I'm very fortunate to have that. But the business case here and how we wrote this proposal was really what I mentioned earlier, that well-being initiatives help to sustain the palliative care workforce. We need that. We need these programs in order to make sure that the patients always have access to a trained palliative care team. We did this work in a team. It was myself, our chaplain, Rabbi Edith Meyerson, our program director, Sasha Perez, and we did work with an outside consultant, Rabbi Stephanie Colin, who had expertise in community organizing. And I mean by that community building and activism that she was doing in an organization completely unrelated to healthcare. We wanted to see what we could take from that expertise and apply to our healthcare setting. So we've wrapped up year one of this work, and year one was really about learning. Listening campaign, in other words, learning what makes people in our department feel most connected. We started by training our team. We recruited a diverse team of 20 people. We asked for peer nominations of people that had leadership skills or had the ability to be influential people that could build a community. We made sure that they represented, we have a large department across multiple sites. We made sure that our team of 20 represented all the different sites and roles, inpatient and outpatient, social workers and researchers. And that team was trained up in community organizing techniques. They met monthly for an hour and a half with our consultant and learned how to approach building community. The next step was story sharing. So the core team, after getting their training, they launched the listening campaign and basically met one-on-one at first with a large number of department members, and then added to that with some house meetings, which were conversations in groups. And we reached more than 100 department members out of about 250 total. For the one-on-one conversations, coffee was provided, and conversation prompts were provided for both the one-to-ones and the house meetings. At the end of the year, the core team was acknowledged for their work. They shared their outcomes in a department-wide meeting. It was very inspiring. We got a lot of amazing feedback from people around the department feeling like this movement is very real. It has the potential to be really impactful. And we also had a small in-person celebration for the core team to thank them for their work. So what did the conversations look like? In our one-to-ones, which we were able to provide coffee, we asked people to think and tell each other, why do you do this work? What do you feel is your purpose and your mission? Where do you find meaning in your job? What has been your experience working in our department in 2023? What do you hope might come out of these conversations that would make it a better experience for you to be part of our department? What do you wish could be different? We analyzed the conversations. The core team did take notes on these conversations, and what we learned was a lot of problems or potential problems were identified in these conversations. Things that people were really noticing was impacting their daily work and maybe negatively impacting it. So when we launched into house meetings, we decided to do a subtle reframe, and we wanted to utilize an appreciative inquiry approach to hopefully inspire a little more hopefulness and ask people to be a little bit visionary. So we asked in our house meetings, we asked people to imagine our workplace in 3 to 5 years. What is better? What is one change that our department made to get it there, that got it there? And this appreciative inquiry technique, I learned this from the Stanford Wellbeing Director course, so I want to properly attribute that. But we did find, as we had hoped, that we were able to get people to imagine some positive changes and got some really creative ideas out of these meetings. Here are some lessons learned from our work so far. The first is that no one wants to feel alone. This theme was resonant throughout all of the conversations. Every member of our community wants to feel seen, feel that they belong, collaborate professionally with their colleagues, and have personal connections at work, personal and professional connections. Department members want purpose and meaning, and so the barriers to meaningful work, things like bureaucratic tasks, scarcity of resources, moral injury, fragmentation of work responsibilities, isolation, all of these are things that present barriers to those feelings of purpose and meaning and really feeling belonging to the community. And, to really break that down, if I'm spending 25 to 50% of my day on a computer, that means I'm not connecting with my work community. The community building process is the product in a lot of ways. What we meant by that is, we weren't just gathering data. Systematically reaching out to department members in these one-to-ones and house meetings, we were making personal connections and building community throughout the process of learning about community. In the community building process, the same logistical hurdles that hinder departmental connectedness on a daily basis, not surprisingly, those were also challenges in our community building project. Specifically, I think when we started out, we were envisioning a lot of things happening in person. And what we realized is that the community building project largely needed to happen over Zoom. It needed to happen that way because even though Zoom is not as well equipped for personal connections, it does offer connection to people that are working at different sites or working on completely different schedules. So we had to live within those logistical limitations. We also needed leadership buy-in to make this project successful. We needed supervisors to allow their staff to attend these trainings and conversations. Most important lesson learned, we're very hopeful that community organizing can enhance the sense of connectedness in healthcare, and we're planning to do more of this strategy. So year 2 looks a little more like some concrete community actions taking shape. And we've grouped those upcoming actions in year 2, which we've started year 2 now. We have 5 themes. The first theme is equitable opportunities for development of all staff and faculty. This means that we're working towards equitable promotions, equitable access to mentorship. Next is departmental rituals and traditions. These are things like, how do we mark milestones in our department community? So we'd like to think about things like welcome dinners for new staff, farewell sessions for people who are leaving the department. Third is social gatherings and connections. So we want to offer infrastructure to promote people getting together socially outside of work. So maybe that looks like common interest groups, like bird watching in Central Park, for example. 4, collaboration across roles, sites, and disciplines. People want more interprofessional opportunities, for example, for administrative staff to shadow clinical staff, or for clinicians to attend research meetings and vice versa, looking for professional connections and projects to work on together. Finally, how do we enhance connection in our hybrid meetings? A lot of this community building work started because of a need to grapple with hybrid and remote work. So maybe there are ways to enhance the technologies that we're using and that we need to use and continue using. Just one last thing here, a couple of well-being resources for all of you, whether you're an organization leader or a frontline clinician or some other role somewhere in the middle. These are resources for your own well-being and for you to have at your fingertips for your team well-being. So the top is the Center to Advance Palliative Care, or CAPC debriefings. These are confidential sessions and they're open to all. They're facilitated sessions for debriefing the challenges of work and discussing coping strategies. So if you go to the CAPC website, CAPC debriefings, you can easily find this or by Googling it. And there's a website link there right at the bottom. The next plug is for the AAHPM, the American Academy of Hospice and Palliative Medicine Special Interest Group, the Wellbeing, Wellness, and Burnout Forum, and I am the current chair of this forum. We have the online message board on the Connect forum where people share resources or questions, sometimes personal experiences, and we also offer community events. As a lifeline, I want you all to have this information for the National Suicide Prevention Lifeline. This offers crisis support 24/7. You can call or text 988, or you can go to 988lifeline.org to reach a trained counselor for suicide counseling. These are my references. This is where you can reach me if you want to talk about any of this. I hope that I've given you a lot to think about, or maybe validated some things that you've already been thinking. If you have any questions about any of the evidence I shared or my thoughts on how to approach this, I really welcome a discussion about this. And the more that we connect and talk together about well-being and share some strategies together, the more powerful we'll be to really make an impact on the culture in geriatrics and palliative care, as well as healthcare in general. Thank you so much for listening to my talk. I hope to meet you in person soon or on Zoom.